Dear doctors, therapists, and orthotists, welcome to our online webinar. My name is Nikola Jevtić. I'm the president of the ScoSym Symposium and international shot instructor. I'm delegated to welcome so many of you from all parts of the world. It's my great pleasure to open our first online symposium on the topic of current trends in research on scoliosis and other spinal deformities. I'm also proud that we have too much participants on our first online webinar. We have prepared very interesting and engaging topics this year and panelists who are highly recognized professionals in their field. As a chairman of this session, I have had the opportunity to preview all the papers that will be presented, and I believe you will find that this program is unique and will definitely be beneficial for your work in future. Now I will tell you something about ScoSym. ScoSym Symposium was founded 2019, and it held first time in Novi Sad, Serbia last year. We had a very successful meeting with more than 200 participants, and also we had 12 keynote speakers. Organizers of the ScoSym meeting, ScoSym Symposium, are the Scolio Centar, Novi Sad, Serbia, CERNS, Novi Sad, Serbia. We should have this meeting, second ScoSym, at the end of June this year, but because of the global situation in the world, because of the COVID-19, we definitely postponed our second meeting, and as soon as possible you will have information about new date of this meeting. Till that time, we will have online webinars, and all of these participants and let's say all of these speakers will be presenters on online webinar. That all our online activities are free of charge, and you can join for free. All information you can see on our web page and Facebook and Instagram pages. We have confirmed sponsors for this year. Gold sponsor is the Center for Corrective Gymnastics Stav Bijeljina, Bosnia and Herzegovina. Then silver sponsor, Acıbadem Hospital, Istanbul, Turkey. Confirmed ScoSym exhibitors for this year are Scoliosis Spine Laser, Athens, Greece, and Hedef Spine, Istanbul, Turkey. Friends of Symposium are Hotel Garden, Novi Sad, Serbia, and Ortho 8, Belgrade, Serbia. Now, it's a big pleasure to say some words about our panelists, our speakers. Our first speaker will be Dr. Professor Theodoros Grivas, and he will talk about etiology of idiopathic scoliosis. Now I will say some about the biography of the Professor Grivas. Dr. Grivas, Theodoros Grivas, is orthopedic and spinal surgeon, graduated the medical school in Aristotle University of Thessaloniki, Central Macedonia, Greece. He completed his training in general surgery in pediatric and adult orthopedics and traumatology in Greece and received MD diploma. He also received a PhD degree. He is a member of the Hellenic Association of Orthopedic Surgery and Traumatology and of the numerous of other scientific societies. He is a member and traveling fellow of both AAO Spine, AOA, and SRS. He served as an IRSSD, SOSERP, and Hellenic Spine Society president. He wrote or was the editor of 9 books and numerous 630 scientific publications and presentations. He was scientific responsible principal investigator or collaborator of 20 research projects financed by Greek national or European source. Currently, he is a director of the Orthopedic and Traumatology Department at Tzaneio General Hospital of Piraeus, Greece, and member of the National Examination Committee for the specialty of the orthopedic and traumatology. My second speaker today is the Professor Dr. Rene Castelein, Utrecht, Netherlands, and he will talk about the role of the sagittal profile in scoliosis. The Dr. Rene Castelein is Professor of Orthopedic Surgery and Chairman of the Department of Orthopedic Surgery at the University Medical Center Utrecht, the Netherlands. He started his career in general practice. His academic practice in Utrecht was focused on spinal deformities, both clinically and scientifically, especially in the field of etiopathogenesis of idiopathic scoliosis. He has published over 150 scientific peer-reviewed papers and number of book chapters. He supervised around 30 PhD theses and presented keynote lecture at the International Society meetings. He was the Harrington Presidential Guest Lecturer at the SRS meeting 2019 in Montreal on the topic of the etiology of idiopathic scoliosis. He was a visiting professor at many prestigious international universities, has been the president of the Nordic Spinal Deformity Society and of the International Research Society of the Spinal Deformities, IRSSD. Holds committee position in the Scoliosis Research Society, is a board member of the International Group for Advancement in Spinal Science and was the vice president and scientific secretary of the Dutch Orthopedic Society. He is a member of and has received research support from the number of international scientific societies like SRS, European, AO Spine, and Foundation Grivas Cortel. Then my third speaker today is Mr. Joe Bryan, National Scoliosis Foundation, Boston, US. Mr. Joe Bryan will talk about the early detection of scoliosis, and now it's my pleasure to also introduce Mr. Joe Bryan. Joe Bryan is the President and Chief Executive Officer of the National Scoliosis Foundation in the US. He joined the National Scoliosis Foundation of Directors in 1978 and has been passionate advocate worldwide early detection and optimal care of scoliosis for more than 40 years. He is also co-founder, former president, and advisory board member of the Society of Scoliosis, Orthopedic and Rehabilitation Treatment, SOSOT. He hosted the first North American SOSOT annual conference of the State Conservative Care in Boston, 2007. In addition, the Scoliosis Research Society elected Mr. Joe Bryan as a honorary fellow member in 2006, and he has continued to serve as an advisory member of the Health Policy, Patient Education, and Non-Operative Committee since that time. Now, I would like to invite Professor Theodoros Grivas to give his presentation and to say something about the etiology of scoliosis. Dr. Theodoros Grivas, please, you can start. Thank you.
Good afternoon to everyone. I would like to congratulate Nikola and his team for organizing this very useful webinar and to thank him for his kind invitation to speak on etiology of idiopathic scoliosis. Hopefully everyone can see my slide. Can you? Okay. Let's start with some definitions. Etiology means the factor or factors causing the idiopathic scoliosis, IS. Pathogenesis is the mode of origin of the morbid process. Pathomechanism is the sequence of events of the evolution of the structural and functional changes that result from the pathological process, and etiopathogenesis embraces etiology and pathogenesis. Professor Barwell suggested the word scoliogeny as the collective noun to include etiology, pathogenesis, and pathomechanism. A range of concepts and hypotheses were proposed to explain pathogenesis rather than etiology, and these include genetics, central nervous system, skeletal spinal growth and bone metabolism, metabolic pathways, biomechanics, and others. Let's speak about genetics. The heritability of AIS is indicated by increased risk of developing AIS in first-degree relatives, by twin studies where it was shown that higher AIS concordance rates were found in monozygotic twins, and in Swedish twin registry where the heritability was 38% as a genetic effect and 62% as an environmental effect. There are several genetic approaches, linkage and inheritance mode, candidate gene association studies, genome-wide association studies, exome sequencing, and other approaches. For example, results from a genetic and genome-wide association study resulted in a theory to a potential link between AIS and molecular biological and axonal guidance pathways. Additionally, a concept of AIS pathogenesis involves a cascade linking the leptin body composition effect to both the development of central nervous system and the asynchronous neuroosseous growth mechanism. The genetics. AIS heritability seems to be a complex polygenic model with considerable genetic heterogeneity, but a specific mode of inheritance has still not been resolved. Several models of inheritance were far proposed. You see here numerous chromosomal regions related to the etiology of AIS, and these were suggested that initiate scoliosis. A genetics test was developed, the Scolio score, but this test recognizes which curves will progress scoliotic children, but there is still a question whether it is useful to reveal this risk of developing IS in healthy children as well. Professor Barwell spent probably all his life studying etiology of idiopathic scoliosis, and he wrote that IS seems to be a multifactorial condition. There is a view that there are two scoliogenic processes, namely the initiating or inducing, and those that cause curve progression. I'm not going to read all these titles for the scoliogeny theories, hypotheses, and concepts, but I'm going to take you through. In this publication, the authors are analyzing the concept of asymmetric stiffness of the ligaments and asymmetric stiffness of the intertransverse ligament and ligamendum flavum, and they considered this as an initiation factor. The relative anterior spinal growth concept. The anterior components of the spine are longer, the posterior elements, and results in torsion progression by the oblique deflection and growth and gravity applied to vertebral growth plates. Milan Roth's original work on disproportion of vertebral growth states that during growth, spurs of elongation of the vertebral column may be too rapid for the slower growth rate of the spinal cord and nerve roots. This resulting disproportion of growth between spine and nervous system is compensated for by adaptive scoliotic curvature of the otherwise normally growing spine. The thoracospinal concept of Professor Sevastik. I just would like to say also that Professor Sevastik was one of the members of the Nobel Committee. This concept is describing that there is a dysfunction of the autonomic nervous system. There is an increased vascularity of the anterior hemithorax, and this is resulting on overgrowth of the periapical ribs, which disturbs the equilibrium of the forces that determine the normal alignment of the thoracic spine in the putative growth conflict. And these triggers the thoracospinal deformity simultaneously in the three cardinal planes. I'm not going to speak about the dorsal forces created axial rotational instability, because our second speaker, my good friend, Professor Rene Castelein, will beautifully analyze this concept. The biomechanical spinal growth modulation. Ian Stokes proposed it in 2006, the vicious cycle. There is a spinal curvature, asymmetrical loading, asymmetrical growth, and wedging of the vertebra, and this cycle is carrying on viciously. Let's see what's happening in the vertebral discs. It was published that the convex side elevated there is convex side elevated synthetic activity than IVD end plates compared with normal tissues. Additionally, the elastic fibers network of the annulus fibrosus of the IVD scoliotic human disc is sparse and disrupted. Also, accelerated disc degeneration in scoliotic versus physiological aging IVD, which develops against a background of enhanced anabolic gene expression. In 2006, we published that co-bancal progression in AIS begins in the disc level. I would like to present some more conclusions of our research work from our group, and we exerted different loads in the rat tail using this mini Lizarov external fixators, and this asymmetric loading results in, and then we studied the findings in the vertebral disc. Asymmetric loading results in accelerated degeneration at the IVD molecule level with the production of MMPs. MMPs are interstitial collagenasses. This experimentally induced scoliotic deformity on the rat tail IVD results in overexpression of MMP1, which is dependent on the degree of the deformity. Additionally, after application of asymmetric loading in the rat tail, there is an expression of MMP12 increased in the IVD, but decreased in the growth plate and correlated with the degree of the deformity and the side of the Goetz disc. Vassiliadis, it was the MD thesis of one of the colleagues of the group, Dr. Vassiliadis. One item of the research was related to pleiotrophin, which is a growth factor with a putative role in the remodeling through its receptor protein tyrosine phosphatase beta zeta. The molecular response of the end plates and IVD to static axial and asymmetrical loading via PTN and its receptor depends on the type and the integrity of the applied mechanical forces. This metabolic effect, I'm going back on. This metabolic effect was associated with an altered biomechanical environment in spinal deformities like scoliosis or kyphosis, and this was the work of one of our colleagues, Dr. Kaspiris. Now he is working in the University of Patras. We postulated that the intervertebral disc wedging is a significant progressive factor for mild IS curves. This concept introduces an innovative comprehensive model of IS curves progression based on the IVD diurnal variation and the subsequent pathobiomechanics pathoremodeling of the deforming three-joint complex. Dr. Kirkatli-Willis presented this concept, the three-disc concept, the disc, the three-joint concept, disc, and the two facets. In the growing vertebral end plate, the growth plate, the forces are transmitted increasingly in the proliferation and helping the proliferation of chondrocytes in the hypertrophic zone of the end plate. we know that in the scoliotic curve, the nucleus pulposus moves toward the convexity. Nucleus pulposus is absorbing water through the glycosaminoglycans when the disc is not loaded, when we sleep, when we lie down. And during the day, when we stand up, it is loaded and the nucleus pulposus is expelling the water. Therefore, there is something like an accordion phenomenon. And this is very important because during the day, the disc, the height is less, and during the night is higher. And as a consequence, there is a asymmetrical spinal growth because the end plates are asymmetrically loaded during day and night, and we have this accordion phenomenon. In other words, we have a vertebral pathoremodeling due to the alteration of the mechanical environment, the modulation of the endochondral growth of the immature vertebra, deforming load, elastic IVD, immature spine deformation, and deforming loads, the accordion phenomenon. And this is an animation of what is happening. There are some more concepts: motor control disorder, an abnormal pattern of brain activation in secondary motor areas during movement execution in patients with AIS. The hypothesis is that a sensory motor integration disorder underlies the pathogenesis of idiopathic scoliosis. Indeed, if we have functional magnetic resonance imaging in controls and in IS patients, and if we do the conjunction analysis, in other words, mixing these two, we see differences in motor task activation. You see here motor task activation across the two groups. There are several other scoliogeny theories, hypotheses, and concepts. The developmental instability and symmetry control dysfunction proposed by Kohlberg, the sensory motor integration disorder and dystonia presented by Domenech, sensory integration disorder by Beaulieu, vestibular disorder, body spatial orientation disorder, and for the vestibular disorder, in MRI segmentation and morphoanatomy analysis of this system, we can recognize semi-singular RR significant group differences. Also, the hypothesis of genetic predisposition of inner ear defects and development in IS. The hypothesis is that gene defects will result in the development of a defect in the inner ear anomalies. This will lead to vestibular rebalance, and this will induce an asymmetry of the tonic activity of the spinal muscles, and this could lead to spinal deformity. Professor Barwell also introduced the neurodevelopmental disorder. For this disorder, we must have first Kerr progression, rapid spinal elongation and adolescent growth spur, maturational delay of the central nervous system body schema, and for the movements of spine and trunk and upright posture. Also, he introduced the intrinsic growth plate asymmetry hypothesis. This hypothesis has AIS as a disorder of abnormal bilateral skeletal asymmetries, and their putative genetic and epigenetic origins in enantiomorphic growth plates of spine of girls with AIS. Enantiomorphs mean mirror image forms. Also, he introduced the neuroosseous timing of maturation. Actually, he introduced the name because this theory was introduced by Nachemson. He was claiming that girls enter adolescent growth spur in postural immaturity, while boys enter adolescent growth spur in postural maturity. And this postural immaturity of girls, due to the earlier entrance to growth spur, makes them more susceptible to Kerr progression than boys. Additionally, and finally, this was the last very important paper written by Professor Barwell, and the proposal of a multiple pathogenic progress double osseous neuroosseous theory. In AIS progression, the AIS progression is attributed to rapid skeletal enlargement, and for this enlargement is responsible the autonomic system, nervous system, which cannot be followed by delayed maturation of posture, and for this maturation is responsible the somatic nervous system. In AIS, a mutational hypothalamic upregulation to leptin produces deforming asymmetrical growth in vertebra, left, right, front, back, and torsionally. This is a rather complex theory, but for the people who are attending the meeting, I strongly suggest to read this paper in Scoliosis, which is an open access journal, and will have all the information and details of this theory. There are some more systemic and metabolic disorders: platelet calmodulin, melatonin signaling defect, osteopondine, estrogens, leptin, and osteopenia. The platelet calmodulin dysfunction. Increased calmodulin levels in platelets have been shown to be associated with progression of adolescent idiopathic scoliosis. Just to mention that melatonin is calmodulin antagonist. The theory, the concept of genetics and epigenetics. This concept, a combined genetic and epigenetic model, is presented here. In order to have the disease, the deformity, there must be some predisposition genes, and then the action of environmental factors, and these two are onset the AIS. There are also some progression genes and AIS progressive factors, and the end is a curve progression and the severity. We have therefore the AIS initiator factors and epigenetics, and I have to say that epigenetics are not written in the genome, are working outside later on when the child will be born after birth. And there are three mechanisms working for epigenetics: DNA methylation, RNA-based mechanisms, and histone post-translational modifications. These are silencing or activating the gene in order to have the reaction. There are several environmental risk factors for AIS, let's say relative osteopenia, physical activity, geographical latitude, and so on. I hope that Nikola will post this lecture and people will read all this. In normal embryonic development, there are some interactions. We have the genotype, the internal-external environment interactions at the cell, tissue, structure, and organ level, and then we have the normal phenotype. Similarly, in scoliosis, we have the AIS genotype, internal-external environmental interactions, also at the same levels, and finally, the AI deformity. You can visit and read this article to see all these details of this concept. Actually, the human evidence-based study of AIS etiology is coming from analysis of the data collected from the school screening, because it's the only way to study human beings and not rabbits or, rats and animals. And the contribution to clinical research of idiopathic scoliosis, scoliogeny, is very important. I mean, the school screening. And I can tell you that we have information on prevalence. All this, which I'm going to read, these information is coming from school screening. The prevalence of AIS, the age at menarche, the role of melatonin, menarche and laterality of scoliotic curve, brain function, morphology of thorax, the double rib contour sign and the rib index, the lateral spinal profile, the intervertebral disc, cavus foot, somatometric data, parental age at birth, body mass index in relation to truncal asymmetry. Also, you can have all this literature, the publications derived from the analysis of Greek school screening data. Professor Barwell in 2002 published in Research into Spinal Deformities 3 a paper entitled Biology is the Future of Scoliosis Treatment. I think that this is very promising, even though prediction, especially in medicine, is fraught with peril. I'm in line with this concept because skeletal biology can never be divorced from mechanics, because skeletal cells are mechanocytes being very sensitive and responsive to mechanical factors. Thank you.
Thank you so much, Dr. Grivas. Now, I would like to give the word to Dr. Rene Castelein. Please, Dr. Rene Castelein, could you share your presentation? And microphone, please. Yeah.
Can you hear me now?
Yeah, thank you. Yeah.
Okay. Okay, well, first of all, great job, Theo. This is always very difficult because we're looking at scoliosis from the moment on that we recognize it as a scoliosis. So it's very difficult to define factors that initiate the deformity, because we only see it when it's there, when the deformity has really developed already. So Theo, great job. Thank you very much for that.
You're welcome.
So now I'm very happy to talk to you on the role of the sagittal profile in scoliosis, one of my hobbies basically. But first of all, let me thank Nikola and Marina and the whole team for organizing this. We've been without meetings for a long time, a couple of weeks, which is unusual in our profession. And this for me is the first meeting that I'm participating in since the pandemic broke out. So it's very nice to be here and to talk to you, and I hope we have very interesting discussions after this session. So thanks again for organizing it. So, yeah. So these are my disclosures. I get some support for my research. It goes all through my hospital. I don't receive any of it, but it facilitates the research that I do. And this lateral plane, or the sagittal plane, this lateral aspect of the spine is definitely not something new. We've heard about that for a very long time. Nicola Doni in 1904 wrote a beautiful book that I like to refer to. And he already mentioned that the spine is extended in the sagittal plane in scoliosis, and also people before that, like von Meyer in the 19th century, already mentioned that. So it's been known for a long time, and actually I believe that the anatomists of the 19th century knew it better maybe than many clinicians from the time on that we had radiography, because on the X-ray we don't see that so much anymore. So the anatomists were very much aware of what happens in all three planes, and we're only now rediscovering that more or less. So for me, the basic question is, what is scoliosis? So that's not the SRS definition, the Scoliosis Research Society definition, because that says it has to be a curve in the coronal plane of 10 degrees. But I think that is not you know, that it's a definition, and we can use it for certain purposes. But I think it's much more than a curve in the coronal plane. And for me, scoliosis is something that happens in the transverse plane, in the horizontal plane. And I'm talking about the sagittal plane. And then we've had all planes that are possible to discuss. But for me, it starts in the transverse plane. And that sagittal plane has very much to do with that. And I'll talk to you about that just a few minutes later. But for me, it starts in the transverse plane. And I'm in very good company, because Jean Dubosset, very famous from France, he has always said that it's a deformity in the horizontal or the transverse plane. And he has a lot of literature. I got this slide from him that refers to that transverse plane. And also with the EOS, with the top view, we can now see how that transverse plane rotates around the different axes, because it's really not one axis. But anyway, it's a rotational deformity in the horizontal plane. So the question is, how come that spine starts to rotate? We are certainly not the first species to have a spine. The spine has been around for 250 million years. Dinosaurs had spines and different components of their spines that are very similar actually to what we have, with intervertebral discs and vertebral bodies and a spinal canal, and transverse processes and spinous processes for attachments of muscles and the little intervertebral joints. So the spine is not a new development or creation. It's been there for a long time, and it's never been described in other species than in man that it starts to rotate. We are really the only vertebrate, the only mammal at least, that develops a spontaneous rotation of the spine. There's some fish species that are being studied that may have something that looks like idiopathic scoliosis, but on fish, of course, there's no gravity, but they have an actual loading of their spine because they swim against the resistance of the water. So there may be some similarity. I'm not too sure about it, but there's definitely some evidence that fish may develop some sort of a scoliosis that looks like idiopathic scoliosis. But all the other vertebrates, when they develop a scoliosis, it's either a post-traumatic scoliosis, or it's a neuromuscular scoliosis, or it's a congenital scoliosis, but not an idiopathic scoliosis. So why would that spine of us as human beings all of a sudden start to rotate after we've gone through a period from birth to about the age of 10 until the beginning of puberty, where the spine has developed in a normal way, and then it starts to go wrong, and it develops a curvature that can become very serious over the course of maybe only 1 year. So what happens there? That's intriguing. And it's my belief that that has to do with man's unique sagittal alignment, because what we have is a triple lordosis. And I think we should realize that we're the only species that has that. All spines in nature are very much in a kyphotic form. We have, of course, a lumbar lordosis. Other species also have a cervical lordosis to a certain extent, but we, as the only ones, also have a pelvic lordosis. And we did some studies on that where we looked at big primates that we took CT scans of their pelvis and compared that to human beings. And we were also able to compare that to these two very old skeletons of Lucy and Turkana boy. They were not maybe fully human yet, but they were humanoids. They were similar to humans. Were they apes or were they human? It's still a matter of debate, I believe, but I think there's evidence that they were more human than that they were like the average ape. And that also shows in the shape of their pelvis. And here you see some values where we looked at the angle that the ischial bone makes with the iliac bone. So that's the lordotic angle between the ischial bone and the iliac bone. I cannot point it out by my cursor, doesn't work here, but you can see the yellow lines of the ischial bone and the other line, the bluish line of the iliac bone. A certain definition to it. You can read that in the literature that we wrote on it. We published on that topic. But what it shows is that that angle between the iliac bone and the ischial bone is very small in the gibbon, the siamang, the bonobo, the chimpanzee. Only the bonobo has a little bit of a lordotic angle, but those two very old skeletons, Turkana boy and Lucy, had some more of an angle between the ischial bone and the iliac bone. So they had already what we call a pelvic lordosis, and that pelvic lordosis closely relates to the pelvic incidence. As we all know, much more familiar with the pelvic incidence than with the pelvic lordosis, but they're linearly related. And if you look at pediatric Homo sapiens, the younger children, they have a lower ilioischial angle and also a lower pelvic incidence, and the adult has the highest pelvic lordosis, but also the highest pelvic incidence. So it seems that the pediatric human population resembles a little bit more of a primitive species, actually. And once we grow up, once we reach our adult life, we develop our specific sagittal plane with the pelvic incidence and the pelvic lordosis. So here you see on the side that we have that pelvic lordosis. On top of that, we have a lumbar lordosis, and then at the top, we also have a cervical lordosis. So we have a unique sagittal profile, and that is also because we can extend our hips and knees fully. We're the only species that can walk with simultaneously extended hips and knees. All other species flex their hips and knees when they ambulate, and that leads to a very different biomechanical situation, because in all vertebrates, the loads on the spine are in an axial direction along the axis of the spine, but also in an anterior direction due to the gravity and also the components of the muscle force. But only in man, we're the only ones, and I've moved my screen a little bit because all the pictures are on top of what I'm trying to show in the corner. But only in man, we can see that there is, next to that axial loading, certain areas also have anterior loading, but we have also areas where the loading is in a posterior direction. That posterior direction is because we have that specific sagittal shape, and that posterior direction leads to a very different stability of that spine. And if you question if we really have posterior loading of the spine, you can see it right here, because, oh, and now I see my cursor. Here you see an MRI of a degenerative spine, and what you see is here the effect of years with axial loading. The discs have worn out and there's really no disc anymore. That is because the axial loading has become too great. Here you see an anterior loading over the years that has become too great. The vertebrae has slipped forward. And here you see that the vertebra has slipped backwards. So these forces must act on that spine because otherwise there would be no reason for a vertebra to slip anterior or posterior. So the question now is, what is that effect of that posterior shear or the dorsal shear? And we did an ex vivo study on that about 10 years ago maybe, where we looked at what happens if you load a spinal segment in an anterior direction, and that's the green arrow. Those are the vertebrae in the normal human spine that are anteriorly loaded. The loading is in an anterior direction. And we also looked what happens to the vertebrae that are posteriorly loaded. And if you look at the green arrow, once we increase the anterior loading, it makes the segment very stiff. There's really no rotational possibility because we compress the facet joints and there's really no motion there. But if we increase the posterior loading, the red arrow, what happens is that the facet joints become more loose and we notice that the segment becomes rotationally unstable. So what that shows is that we have three forces that act on the normal human spine. All other vertebrates have only two forces. Other vertebrates have these axial compression loads and these anterior loads. We are the only ones that have the posterior loads. And if this anterior loading becomes greater than what the body can handle, something goes wrong. And what we see is something that we're very familiar with. We see a spondylolisthesis where the vertebra slides anteriorly. If that axial loading becomes too great, we get what we call a Scheuermann's disease. That is, if it happens during growth, if it happens in an acute sense, it's called an impression fracture, but during growth, we call it Scheuermann's disease. And if we have that posterior loading that becomes too great for what the body can handle, the spine starts to rotate. So it's a very mechanical explanation of what happens, and there's many things we still don't understand, of course, because why does it happen in one and why doesn't it happen in all the others? Because we know scoliosis only occurs in 2 to 4% of the population. So we still don't have all the answers. Of course we don't, because it's way too complicated for that. But we can say that scoliosis is a rotational deformity, and the rotated segments correspond to the backwardly inclined segments that only exist in the human spine because of its unique sagittal profile. And this is, of course, very hard to prove because like what I said after Professor Grivas' lecture, we only look at scoliosis once the deformity is there. So it's very difficult to say if what we see and what we study is the cause of the scoliosis or if it's the result of the scoliosis. It's very difficult to prove all these different theories that we have on etiology of scoliosis. But here you see an example of a group of patients with a high risk profile for developing scoliosis. And we took x-rays of them in 2012. And you see in the coronal plane two very straight spines, nothing wrong with them, but you see two very different sagittal planes. And these sagittal x-rays were taken in a very standardized manner. But this sagittal x-ray shows a pretty steep posteriorly inclined segment, and this one is a much longer but less steep. Both spines are still straight in the coronal plane, and if you wait long enough, this patient that had the straight spine in 2012 with this sagittal profile develops a thoracic curve, and the other one with the lower backwardly inclined segment but more steep, they develop the lumbar scoliosis. We did a study with a group of Suk and Shah where we looked at the differences in gender. And what we looked at is how many vertebrae were backwardly inclined between boys and girls at the moment of their peak growth velocity. And what you see is that the female spine during puberty, when growth is at its fastest, has more vertebrae that are backwardly inclined. And I would call those the ones that are at risk for starting to rotate. So girls have more vertebrae at risk. So maybe that's a good explanation why they develop the scoliosis more often than the boys do. This is what we just saw, I would say. But we also looked at the differences in the sagittal plane between thoracic and lumbar scoliosis. Again, you don't want to look at the scoliosis once it's fully developed. So we looked at very minor forms of scoliosis, and we looked at the coronal plane, but also at the sagittal plane, curves that were only between 10 and 20 degrees, so you could call it a scoliosis, but very minor. You see it here, a minor thoracic curve and a minor lumbar curve. And what it shows is that these sagittal planes are different. Even in the very early curves, the sagittal plane of the thoracic scoliosis is different from the sagittal plane of the lumbar scoliosis. And the vertebrae that are backwardly inclined in the sagittal planes are the ones that become rotationally unstable in the horizontal plane. And why the thoracic goes to the right and the lumbar to the left, I can explain that, but it's not part of my lecture. But that's because we already have that pre-rotation in our spines, even as we have a normal spine. So this is about the biomechanical explanation of the rotational instability. What's the other thing in the sagittal plane? That's that relative anterior spinal overgrowth, so that extension of the spine that has been described as a cause of scoliosis, and Professor Grivas mentioned it in his wonderful overview. There's no doubt that there is a overgrowth of the anterior part of the spine. The anterior part of the spine is definitely longer, but that has been linked to the pathogenetic mechanism of the scoliosis. I don't think that is probably true. There's no doubt that this is the case. This is, if you unwind the scoliosis, it's what it starts to look like. But if you look at normals, you see a normal thoracic kyphosis. If you look at idiopathic scoliosis, you see a thoracic lordosis, if you really derotate it and look at it from the right angle. But also in neuromuscular scoliosis, we did a study on that. We saw that the anterior aspect of the spine in neuromuscular scoliosis is longer also, and even in the compensatory curve in congenital scoliosis. So if you have only two vertebrae that are not well developed that cause a congenital scoliosis, you develop a compensatory curve, and also that curve is longer anteriorly. And that anterior length is only in the discs. It is not in the bone. The bone in all these curve types is in kyphosis, but the disc is wide open, and the disc is longer anteriorly than posteriorly. So it's not bony growth, it's more passive expansion of the disc. And we recently, excuse me, had a chance to look at a whale that got stranded with on one of our beaches, and it appeared to have a scoliosis, and that was caused by trauma to the spine. These are impression fractures of the spine, but we didn't look at the area where the trauma occurred, but the animal, of course, wanted to straighten its spine because otherwise it couldn't swim anymore. So this was where the damage was done, but this is the compensation that the animal made itself to get its head in line with its tail. And we looked at the three-dimensional aspect of that compensatory scoliosis, and also that was in a lordotic configuration in the discs. These are the discs, that is the bone. So the discs are wide open also in that fish, or actually it's a mammal, but it came from the sea, so I tend to call it a fish. But that developed a scoliosis as a consequence, as a compensation for a trauma, and also the anterior length of the spine is longer than the posterior length. So anterior overgrowth is not active bony growth. It's not exclusive for AIS, and once the spine decompensates, the 3D morphology of all these scoliosis types is very much the same. So we believe that these posterior shear forces are the basic initiation of the scoliosis. That means that due to those shear forces, the spine starts to rotate. Due to that rotation, the anterior aspect of the disc is not loaded anymore, so it can expand and become longer, leading to that anterior additional length, leading to the thoracic lordosis. We believe that that is the sequence. So the conclusion of my lecture is that idiopathic scoliosis is a rotatory instability of the human spine in the transverse plane. The human spine is rotationally unstable due to its unique sagittal profile. The sagittal plane determines which vertebrae are at risk for rotation. The sagittal shape of the spine is very badly defined because we have many different variations, especially during growth. And the biomechanics of the disc determine the rotational stiffness. Development of the sagittal profile is not well known, and the biomechanics of the disc during growth especially is not very well known either. So I'm sorry if I went over time, but I love to talk about this for hours and hours. So thank you very much for the opportunity to present this material. Thank you.
Thank you so much, Professor Rene. Now we are waiting for stop sharing the screen. Yeah, thank you so much for a nice presentation. Now I would like to give the word to Mr. Joe O'Brien to talk about early detection of scoliosis. Please, Mr. Joe O'Brien, could you start with your presentation? Thank you.
Yes, I will. Thank you very much. I appreciate being here. Fascinating as always, Professor Castelein, and thank you, Dr. Grivas. I'm trying to get this. Hold on one second, please. Having a little bit of technical difficulty. Sorry, we'll be there 1 second. Okay, are we there? Can you see the screen?
Yeah.
Okay, let's go. Don't have to present a few, but we'll just have to go from there. Anyways, I want to thank you very much, Nikola, for inviting me. I want to express my sincere best wishes to everyone who's participating here around the globe during this time of pandemic. As Professor Castelein says, it's a pleasure to be here as we get into our new norms. Nikola had asked me to share on early detection of scoliosis. And I would say up front, I know I'm going to be over because he also asked me to share how we do the screening in some of the places in the United States. So I've added some the end of that to show that as well. Oops. As Nikola had said, I'm from the National Scoliosis Foundation, is an organization that began in the United States back in 1976. One of the founders of it was Dr. Riseborough from Children's Hospital in Boston. A woman by the name of Laura Gowan, who founded the organization, had befriended a fellow from Ethiopia who was believed to have polio there. As it turns out, he had a 145-degree scoliotic curve. Dr. Riseborough had graciously operated on Atlabachu, where he was ambulatory, was able to continue his education, etc. But in the process, Dr. Riseborough had asked Mrs. Gowan to start an organization for really two purposes. One, to make sure that people were aware of it. In the 70s, people did not know what scoliosis was. Secondly, at Children's Hospital, they were, of course, very involved with the Boston Brace. And he said on average, people were coming into his office with 75-degree curves, and he simply had no chance for any non-operative process to be able to stop that progression from continuing. The aim of the organization is for the advocacy of early detection and treatment and to raise awareness about it. We also are very involved in providing resources and support to patients along the way and research around the globe. Our fundamental belief is that every child, regardless of race, creed, or socioeconomic status, deserves the equal opportunity for the early detection of scoliosis and the least invasive, less costly, most effective treatment option possible. As Nikola had described, I've been with the National Scoliosis Foundation for a fair amount of time, over 4 decades. And I am honored to be a member of the Scoliosis Research Society, and perhaps the most important milestone in my life was to meet Dr. Grivas and others and to be able to gather a group of non-operative experts around the world within the SOSOT. I am also was pleased to be a part of the U.S. Bone and Joint Decade, which is also global. And I currently even serve on the Food and Drug Administration of the United States for the Centers of Devices and Radiological Health. In a traditional sense, I have no conflicts of interest. I do say there is a saying in the United States, though, to say that we have skin in the game, and I do have skin in the game, whereby in December of 2017, I had my 6th spinal surgery for scoliosis. So I certainly do have my perspective as a patient as well. So I would deal with both my head and my heart as it goes forward. My journey began over 50 years ago as a 15-year-old male and continued. In essence, I sort of chronicled the development of surgery in the United States, starting with the HIS procedures and ending up with a pedicle subtraction osteotomy. I'm fused from T4 to the pelvic now. And as you can see, in combination, I've had over 600 days absence from school or work and over $1 million in today's dollars, that would be. More importantly, we have a very high prevalence within our family. 50% or 15 of 30 living members have scoliosis, beginning with my mother, as far as we know, over 3 generations. At this point, we do not have any great-grandchildren yet, thankfully, at this moment. That picture there is me after one of my surgeries and my daughter who has a kyphoscoliosis. We have 5 children, 3 of whom, 2 daughters and a son, who also have scoliosis. The son, very interesting, has a mirror image of mine to the left, to the opposite side, but there's no underlying pathology there. Of that group of individuals, we've had 10 who are under 35. Actually, most of them are for between 20 and 35 degrees, 4 are braced, and I am the only one that's had surgery. But I do know from that experience that I have to admit that in many cases, I was the patient rather than my children. We searched as parents to try to find out what is the best treatment for their children. Despite the great knowledge that we have that Professor Castelein and Dr. Grivas has shown us, we know so much, yet we know so little. And at the end of the day, we still have the dilemma of who will get it, why they get it, who will progress, when they progress, and how far they progress when we're talking about idiopathic scoliosis, which is by far the one that affects our adolescents the most, which then causes confusion and stress in terms of what to do. And even though we know that there is, in an ideal world, we could observe when we're supposed to observe, exercise when we're supposed to exercise, brace when we're supposed to brace, and do surgery when we're supposed to do surgery, in conjunction with the guidelines that SOSOT put out, we do know that in reality, trying to catch that at the right time is very difficult. So very often, we're concerned about undertreating our children or overtreating our children. On top of that, we know from Deval Boupere that there's a very short window of time to be able to operate between when that spine is occurring and when the growth is occurring. And growth is, for us as a parent, that's the enemy, in a sense, for the adolescent idiopathic scoliosis, and we need to detect that and treat early. So there's a lot of anxiety because time matters. In our perspective, it's not just a 3-dimensional deformity of the spine, it's a 4-dimensional problem. And while this is not the case of my children, it is the case in terms, it wasn't the severity, but despite everything I knew and everybody that I knew, all 3 children went very rapidly. It doesn't happen in a textbook manner, the growth. They went very rapidly from a 10-degree curve to a 30-degree curve in a very short period of time. And although we know that the majority of cases are benign and not going to grow, from our perspective, if you look at it, that's 1 out of 40 we know that's going to have it. And only 1 out of 6 of them will actually progress to that 20-degree level. But then of those, half of those will then have to have some type of aggressive treatment, and then half of those will actually go to surgery. So bottom line is we have 1 out of 4 of them that we can expect to have to go on to surgery. Dr. Weinstein, in his study with Dr. Ponsetti back in 1983, is really seminal. His first was his 40-year follow-up, and then his 50-year follow-up. But in the 40-year follow-up, Dr. Weinstein and Ponsetti had said something that really struck us, and that is that it appeared in his that in general, curves that were less than 30 degrees at skeletal maturity did not continue to progress into adult deformity, whereas those that were 50 degrees or more clearly did progress at a much lower rate, but they progressed over time. In 2003, he had published another study on the health and function, showing that those with the 50 degrees plus could also expect a significant predictor of decreased pulmonary function. All of those put together has made me, with the skin in the game, to be very, I would say biased probably. I could admit that, I confess that, in terms of the primary mission of screening out scoliosis. We need to be able to detect early and treat as early as possible those that need to be treated. Only the progressive cases, which is really the fundamental problem, is how do we identify those that indeed are going to progress beyond that 30 degree and 50 degree levels. Yes, that is me on the left-hand side back in 1978. The first thing that we had done when I joined the foundation is that we did a survey in our own state. And we found at that time that, yes, on average, they were going in with 75-degree curves. And the other problem, though, was that wealth equaled health. Those communities that were had more financial availability, it seemed, did have screening programs, were going to the doctor, did have access to it, whereas those that didn't were the ones that were ending up on the surgical table. That led us, therefore, to the first time to draft legislation and to take on the mission to make sure that all children have access to this. It shouldn't just be the wealthy, it should be everyone. And that was passed in 1980. Now, based upon the information that we knew back in the 70s and 80s, I would say we went overboard in the sense that to this day, we still screen both girls and boys in grades 5 through 9. If we were to do that today, we would not do that extensive of a program. Screening is not isolated by itself. After doing this for a while, it was evident that the issue that was surrounding us is that what are we going to do once we're screening them? We were firm believers in bracing and non-operative care, but we were looking for something else. So in 1996, I bicycled across the United States from San Francisco to Boston for etiology research. Dr. Nancy Miller was at Johns Hopkins and she was starting her genetic program. So we raised some seed funding for her. More importantly, we were able to recruit 200 families that was similar to mine with multiple affected members, and she was able to get the DNA for 1,200 patients. That has been important as a beginning process for the genetics that Professor Castelein and Dr. Burwell and Dr. Grivas spoke about in their presentations. The other part is awareness and let people know. So in 2008, I created the June of Scoliosis Awareness Month program, which has now thankfully gone around the world to try to let people know about the importance of detection and research. So since that time, we have been involved not only just in the United States, but throughout the globe, in Italy and Poland and other places, to try to make sure that children have access to early detection of the problem. Now, not everybody agrees with that. And as we saw in 2004, the U.S. Preventative Services Task Force, which is a group in the United States associated with the government agencies that look at a whole bunch of screening, not just scoliosis. They look at every aspect of screening. In 2004, they came out with a negative statement against screening. And their primary issue is they said there were too many false positives. Basically, there wasn't enough evidence for bracing, and there was nothing effectively could be done if detected. And in essence, if you just didn't do anything, you didn't have to worry about that for surgery. Surgery didn't require detection. Dr. Bill Bonnell, right after that, had published a study on selective screening for scoliosis. The point of his issue was addressing the problem of false positives, indicating that one of the problems with scoliosis is that we have a large group of individuals that will not have to go on for treatment. and that the nature of the condition has created some problems with that. But in fact, as he indicated, you know, the professional societies, the people that work with that, indeed endorse the screening. At the time, based on a study that Dr. Asher had published in 1989, there were 22 states in the United States that required screening based on law, and another 14 that recommended it. So we had 36 states, a majority of our country, that was involved with some form of screening or not. All of them were doing the Adams forward bending test, and then most were using some other type of objective criteria, whether it be a scoliometer or a moray or some other type of device that was available. And he recognized that we were actively involved in that process, which we were. Those societies, the AAOS, the American Academy of Orthopedic Surgeons, the SRS, POSNA, which is a pediatric society, and the AAP, all endorsed screening, and they did not endorse recommendations against screening for that. And they believe, obviously, that we needed education of those individuals who were doing the screening, which we fully recognize. Dr. Chung and his group, or Dr. Luke in Hong Kong, published a study, a large study within China, and you know, their conclusion was screening is predictive and sensitive with a low referral rate, and they should be continued. Dr. Lebel in Canada had published a study after screening had stopped there. Canada was more aggressive in stopping screening before the United States for basically the same reasons. But Dr. Lebel had gone back and looked at his referral patterns and said that he now sees as a problem because children were coming too late into his clinic to be able to get the benefit of bracing. And then, of course, in 2013, we had a seminal large-based randomized prospective study from Dr. Weinstein and Lori Dolan. It was funded by the National Institute of Health, a $5 million 5-year study, the BRACE study, and looking at greater than 50-degree criteria. And this was a multi-centered study, considered a level 1 evidence study. And what they found was, when you looked at observation only versus brace, in observation you had 48% that did not progress to a 50 degrees. But in bracing, we were able to have a 72%. So there was basically a 25% differential in that, indicating that bracing works. In fact, so much so that the ethics committee of the NIH stopped the study early because they thought it was unethical not to treat a child. The basic bottom line was that Dr. Weinstein said is early detection is important. And of course, we need compliance in the child to wear the brace for the dose and amount of time that they should wear it. At the same time, with SOSORT starting to develop evidence, it wasn't just bracing, but it was also the benefit of exercise with our European colleagues who were more aggressive in this stage, and now in the United States beginning to adapt. And since that time, there's been many studies that are starting to be published from the Negrini group, from Dr. Grivas, and from others that are showing, in fact, there is a benefit from early use of exercise and in combination with bracing as well. For our part, in 2013, we were looking to see what the impact was that we could determine. We presented this in Chicago at the SOSORT meeting to see what the impact in US school screening was. What we found was there was clearly a reduction in the screening. The 22 states that Dr. Asher had reported on were now down to 16. The recommended states had been cut in half as well. So we had a significant decrease in the amount of screening that was done within the schools. At the same time, looking at the database specifically for idiopathic, what we saw is there was a trend over a 20-year period of time, but in particular, from 2004, when the US Preventive Services Task Force statement came out and screening started to stop, to 2013, over that period of time, we had an incredible increase, over 80% increase on the amount of surgeries that were occurring and people being discharged out of the hospital. At the same time, the cost associated with that was also more than doubling over that period of time. Now, part of that is good because it's innovation, but the other part was related to the volume of the surgeries that were occurring. We looked further, a little bit more granular to that, and we identified the states that had screening and the states that didn't have screening. And in all cases, as we look here, all the way across in total and for every age group, we found that there were more surgeries that were occurring in the states that didn't have screening than the states that did have screening. Bottom line, our conclusions was that school screening for scoliosis seems to be more cost effective than no screening. And that based upon our initial review, the 2004 US Preventative Services Task Force negative statement against scoliosis screening has resulted in a reduction in the number of children screened, consistent with the intent of their policy. However, contrary to the US Preventative Services Task Force rationale, the reduction in scoliosis screening appears to have caused more harm, not less. In 2015, that group went back to re-look at the issue of screening. And these are the basic 6 questions that they had. We're looking at does screening for scoliosis improve health outcomes and the degree of abnormal spinal curvatures in adulthood? Now they were looking at adulthood, not the adolescent. Was it accurate? Does treatment of adolescent idiopathic scoliosis with a Cobb angle of less than 50 degrees improve health outcomes and the degree of spinal curvature in children or adulthood? What is the association between the severity of the spinal curve in AIS and the health outcomes in adulthood? What are the harms of screening for AIS and what are the harms of treatment for AIS in curves that are less than 50 degrees? As a result of that, when the study came out in 2018, they had an insufficient result. The grade was I, insufficient. Now that was fantastic in terms of moving from a negative to an insufficient. That was a positive move that reflected a lot that had occurred over that period of time and the statements that occurred. However, it still wasn't enough to persuade a lot of people. The conclusions that they drew with the I grade was that, yes, screening can detect AIS. They weren't saying that it wasn't anymore. And yes, bracing can interrupt or slow the progression of the curve in adolescence. And that possibly exercise treatment can also do the same. There wasn't strong evidence, but there was more evidence that was being published on that. But then they went on to say, however, there is little or no evidence on the long-term outcomes for AIS treated in adolescents, or the association between curvature at skeletal maturity and adult health outcomes. There were no studies for the harms of AIS screening or treatment and the effect of AIS screening on adult health outcomes. In response to this, Dr. Resko, Schwend, and Dr. Hostin, representing the major societies with scoliosis, had published this article in the JAMA Pediatrics about what the I meant for them. And in that process, as you can see here, they said the critical concept is that early detection of scoliosis and non-operative treatment, they're inseparable. Those two go together. And if presurgical curves are not clinically detected, patients cannot benefit from the potential surgical risk reduction of a brace treatment program. The recent brace study is very convincing, the ability of the brace to treat and minimize the progression. And that it's very important to continue with the detection so that we have a patient shared decision-making in the treatment of scoliosis in terms of what can be offered to them for their treatment. And then lastly, the statement both from the SRS, the American Academy of Orthopedic Surgeons, the Pediatric Orthopedic Society, and the American Academy of Pediatrics continue to recommend screening. Now, as opposed to what we have in Massachusetts, where it's grade 5 through 9, they're being more selective and saying that should be at ages 10 and 12 years, and boys just once between 13 or 14 years. So from our perspective, looking at it, why school screening? On the left side, we'd already gone through that in terms of all the issues and opportunities that, and knowledge that we have, that we've seen in previous presentations here, et cetera. But on the school side, why school? It's not that we're exclusive for school. We certainly work with and support screening that is in the primary cares, the pediatricians, in all outlets that we can have. That's important, not taking away with that. But the schools are the only place that we have the large-scale population-based screening that can be conducted. So we have a concentration of that targeted population that's there. It does afford us the opportunity, therefore, to provide equitable access to everyone. They do have certified health personnel. And the importance of that is that school nurses that are in there, they don't have any self-interest. There are plenty of groups within the United States that would welcome and do all of the screening. Most of them have an ulterior motive that's not necessarily best for children and their families. And the school screening is consistent with other health-based health screenings that occur within the school. When we look at a population-based postural screening, it's important to remember that this is not a clinical diagnostic exam. We have to take into consideration that the large population-based and what the goals and agenda are from the environment for where we're going. The first element of that is to have the screener education. It's absolutely essential that the screeners be educated in terms of what the condition is, how to properly screen for it. Obviously, the administration of establishing the screening, scheduling, sending out and communicating with the parents and guardians of the child, conducting a pre-screening class with students, which I'll go into, and then a variety of different sources. The recommended model that we use is a 2-level screening. And that's primarily because of the fact that 97% of that population does not have scoliosis. So the goal for them is to get them back into their class and their education goals as quickly as possible. On average, our screening in a first level is a 27-second screening. And then secondarily is then focus on the 3% that may have scoliosis so they can have proper referral and we can begin to document and report that. So we want to weed out those true negatives, train the screeners to see that and get the kids back into school. And then we want to be able to have the school nurse educated enough to confirm true positives before initiating referral process. And the use of the scoliometer for that process for the school nurse, it varies by state because as we've seen in this COVID-19 in the United States, states have the authority. So you can't, it's very hard to get a national standard in the United States. Some states still use 5 degrees, others use a 70 degrees. And in that study that I had indicated before, Bill Bonnell with the selector screening, part of that was to say, well, listen, if we really wanted to get a very high positive predictive value, then maybe we should only look at females, only at 0 to 1 RISA, and only those that are 10 degrees or more within the scoliometer, referencing the angle of trunk rotation. And then that way there we would do it, but that's not necessarily was best for that. And most of the families and other people involved did not take that on as a requirement to do that. The screeners are then trained basically in the common physical attributes that we see in all types of scoliosis, whether it be malposition of the head, leaning of the head, the shoulder levels, the scapula, either protruding or being in different levels, the arm-body space that occurs because of the leaning of the body in the coronal plane that we see very often when the child is standing, hip to obliquity in certain cases, certainly in a lumbar, and the abnormal spinal curve. The Adams forward bending test in order to be able to highlight what is occurring with the ribs within there and to see, use the scoliometer on that confirmation. Or in today's world, there is a whole group of different phone apps that one can use that mirrors the scoliometer as well to be able to tell what the angle of trunk rotation is. This does not tell us the Cobb angle, as you know. This tells us the angle of trunk rotation. It's used more as a trending and not as a specific diagnosis. And then the training also becomes, for a population-based, they have to importance with the process. The process is just as important as that clinical exam, because you are trying to get this large group of students in and out of their environment as quick as possible for that 97% as they had. So it's important, one, you know, in fact, and this is an old picture of myself, and as in that first upper hand picture there, we're sitting, we would never sit anymore. And the reason is because the worst thing you can do with a fifth grader is to have to communicate. The more you have to tell them what to do, the longer that is going to take. If I have an examiner is standing up, then I can go around, I can look from the front, I can look from the side for the sagittal plane, I can look from the back to see what I'm going to do, and I can have them do the Adams forward bending test both from the behind and the front to see what we have to see with very little communication. Typically what we will do is to put a little poster or something here on the board. So there's only one communication we have to give to that student, is that you're doing great, look at the board, or look at the picture. You're doing great, look at the picture. You're doing great, look at the picture. As we go around and do the various positions that we have to do. The only second communication we have to do is, okay, bend over like you're diving. And that would be it. So we just go around and do that and make it a quick screening process as possible. The recommended screening areas for that first level screening is in a large enough space that you can have a flow of traffic. Because you're going to bring in, in our case, I'm speaking at all in the cases that we do here. So you're bringing in a class at a time. That's upwards of 30 children that you're bringing in at a time. For boys, typically we will do it in a gymnasium where we can have a line to identify where they're going to stand, another line for the whole group to be back here as they remove their shirts, and then they can come up. If you have a pool in your school, obviously that is fantastic. We don't have many schools that have pools in the United States, certainly not in those areas that we're trying to get equal access to. For girls, very often we recommend a locker room. The advantage of a locker room is that you can have, for privacy purposes, the girls can be lined up in one row and then one at a time come back in the back end. So like Disney, you can have a rotating cycle of these so that we can move them out as quick as possible. And in cases where screening, privacy is very important, then we can use a variety of different clinical screens in order to allow one child at a time to come around. And there are issues with that anytime you have children. The other thing is that I should have recommended that in that first level screening, we absolutely do not touch any children. There's no need to touch them in that first level. On the second level, when you're using the scoliometer to confirm, then you may have some touching, but very little, and you're down to now maybe 5% of the student population as opposed to the 100% that you're there. Nonetheless, there are still issues with that, you know, to remember for the screeners that this is not a diagnosis, this is only a screening. You need an X-ray to diagnose, you can't diagnose this. Therefore, the little liability in our state, there is no liability. This is by law, so they can do that. Participation sometimes can be an issue for religious purposes or if a child is squeamish, etc. However, that's usually through communication, good communication with the parents and pre-screening that we can mitigate that problem. Privacy is an issue, dress is an issue, location is an issue, and dignity. All of those things can be addressed if you have dignity and allow the child to communicate with them very openly, maintain as much dress as possible that you can do, and communicate with them. And with the screeners, to be sensitive to that. We use a variety of different techniques to, for example, giving out colored paper. So each student will have colored paper. And rather than say something about the child when you screen them, we'll give them a purple if they're fine and give them a red if they're not. And then we'll know to go back and rescreen that child. There's just little ways that you can administer that as you go through. The other thing is, what's really important, what the U.S. Preventative Services Task Force and what Dr. Bunnell had pointed out with the false positive issues is really an issue when you look at postural screening in the schools. And that is because it's one contradicts the other. School nurses who don't have ulterior motives, they have a heart of gold. They're really concerned about missing a child. So they tend to focus on the false negatives. They're worried about false negatives. In the meantime, the school is looking at false positives. They're being judged in the false positive. And if you go through that process, once they understand that, then they can, instead of referring that child on, if a child is in an area of 5 degrees, or they look like they may have something, they have multiple issues, then they can hold that child, wait for 3 months, redo that child again before they refer them out into the process. And that helps to cut down on the false positive rates of sending out. We also will send in the school screening ambassador. Throughout the country, we have these where they'll go and visit local schools, show a video for the students, tell their stories so it can be related to them, tell them how the screening is done. We'll model it with the students, answer the questions they have, and reach out to all of the locals, because it's not just the exam. Again, you have to look at the entire environment and everybody that's involved in that process, in the school and the town and the parents. The Catch the Curve video is a 10-minute video. It's geared for a 5th grade student, first timer, to make those that are the 97% that don't have it very comfortable, curious to understand it. Those that have the 3% not to be afraid of it. It also is a good tool to use for parents as well after the child is being referred out. There is a process that we go through that we provide them with a postural screening report that goes through the items. The first sheet is the screening observations. You can see in here, it's just basic information that has the various positions, that tells them what they're looking at, reminds them of what they're looking at, and gives them a process so they can say left, right, 1, 2, etc. To go through that with all the basic information that's required for us to follow up. In terms of the exam itself, what they're advised is to look at those positions that we talked about posturally, in terms of the head, shoulders, arm space, hips, etc., both from the front, the back. Now, when you look at this process, again, it's not a clinical exam. The rationale for this is that this is just courteous. If you're going to have a student come into you, a group of students, the first thing you want to do is face them and say, hi, how you doing? You know, to just be courteous. You're not going to, everything you're going to see primarily, you're going to see posteriorly. But you first be courteous, you see them, you can identify a few things. Now you look at the back, you look at the side, etc., as you go forward. What we recommend for them is for positive referral guidelines. For those first, the front and back, those physiological, they can be all over the place. So you don't want to have one low shoulder or one item that they're looking at, the waist, etc. So basically, we want to see multiple issues before we would identify them to a second level screening. Until you get to both the Adams or the sagittal view, where you're looking at the curves themselves, and just by identification of that, that's enough to refer them on to be checked with the scoliometer or Scolio screen. For the positive referrals, that's now a communication process. Inform the child in an appropriate manner, call their guardians, their parents, send a letter to them, refer them out to resources that can support them, a letter to the physician for the child, and then treatment follow-up. You can't see this form, it's very difficult. This just reflects all of the reporting for the whole item that's taken place. It's one per school system. It shows their screening results and the physician's exam. We then encourage them if they want. We have a free clinic, they can come. We have a Formetrics machine that allows us to help start to get objective data and to confirm what they had saw within the screening before they refer out, and they can bring this to their pediatrician or primary care before they may be recommended to have an x-ray or not. Now, in the area of looking at screening, we do have some screening devices and methodology that are coming up out of Hong Kong. We do have Professor Chang with the Scolio scan, which is an ultrasound. which has an advantage that is a non-toxic method of looking at the spine. And it has good potential. It seems to have good data in terms of the reliability and validity for that. I spoke this week to Dr. Chung, and what he told me is that it's not just the screening. It's the whole system of referral, conducting the screening, aftercare, and the various workflow logistics and medical legal concerns that need to be worked out in different healthcare systems in different centers across different countries and states. And that's what I was trying to point out, the difference between a clinical exam and a population-based screening program requires a lot of different pieces and parts that have to be coordinated together in order to make that effective and efficient. A colleague, Professor Castelein, with Dr. Brink, had published another study looking at this Scolio scan and confirmed the validity and reliability that they saw within that, and also see it as the possibility of being an effective screening device, perhaps, as we go forward, once we can figure out all those other things to make it effective. And I do hope to see that happening that's there. Now, it's not the only one. We have a variety of different devices. We worked with Dr. Tzaneio, who is actually one of literally is considered the founder of MRIs. And he has a device which is an upright MRI, and in fact has created a process for the identification of scoliosis, which is fantastic because the patient can sit or stand, but they can sit in there fully clothed. So we have the dignity of the patient, which is always our concern. It's a very short scanning process. It's non-toxic, and the cost of it is actually comparable to x-rays for the providers, for the payers, I mean, which is fantastic. The only problem with this, and the reason why it hasn't really gone out there, is that the machine itself cost over $1 million, and it costs another $1 million for the installation. So it has not been very practical in terms of being able to infiltrate throughout. Otherwise, it would be fantastic. We are looking at the possibility of actually trying to put that on a mobile van and then going out as a scan van and offering that. But there are technical issues with the movement of the van, so that we not even being able to accomplish that yet. You know, Dr. Castelein had talked about the torsional rotation that occurs. One of the more interesting ones that we saw that could be a very effective screening was Vert Mooney, who now has passed away. But Dr. Mooney had published a couple of studies looking at rotational movement on a basic exercise device that he had. And it was very intriguing. His initial pilot study showed that, in fact, when you compared it to a control group, there was a significant weakness on the part of scoliotic children going into their concavity. Going from neutral and then rotating into their concavity. And then Dr. Asher followed up with that, in fact, found that in his pilot study, that it was, he found the same thing, that there's clearly a noticeable, significant weakness on the part of the ability of the scoliotic children to rotate in that. And that this was a way we thought could be a fantastic screening tool to be able to have the child sit down and then to quantify and have some objective data in terms of it. Unfortunately, in a subsequent study, which I don't have a copy of it here, but in a subsequent study that Dr. Asher did with Dr. Burton, they were not able to repeat it, and it sort of fizzled and Dr. Mooney died. But I think it's an area, and particularly with the work that Dr. Castelein has done in his etiology and pathogenics of scoliosis, to see whether or not this could be an effective method for screening. And then, of course, we have genetic research, and riding across the country was worth it in terms of it and where today. But like many other things, what we find is that scoliosis is just more complex than we think, and it's very hard to come up with one potential way. Dr. Castelein has published recently on deletion syndrome of 22q11.2, et cetera. We have other data that's been published, but so far we did have a company that came out with what they thought was a tool to identify scoliosis and progression, but it was just found not to be practical from a clinical perspective it wasn't really enough of an add-on, so that stopped. Dr. Alan Monroe and his group up in St. Justine's in Montreal, and Dr. Weiss and others that are Dr. Weiss and others that are doing the research work have provided a lot of information to us, but so far we do not have anything that allows us to either screen a child or be able to tell whether or not the progressive scoliosis is continuing. Now, I did speak to Dr. Moreau, and he does believe that within the next 2 years, he will have something that is able to both identify those that have a propensity towards progressive scoliosis and those that are in fact progressing. Let's hope for that. I was there for the launching of the Viscoliosis Lab, and I think it was 15 years ago, and we're still hoping and waiting for that. And I'm very, I encourage him to continue forward. Now for the other side. And I apologize for these videos. These are actual pictures that were in this article, and it serves a purpose. This is what school screening has been up against on the other end of the picture. These are actual, taken both of these from the Mo Winters Launstein group in Minnesota that were clinical pictures at the time that others have taken, and this was an article in the American Journal of Public Health in 2012, but it reflects what the challenges that we have when you look at postural screening in a population-based process. And this article refers back to the first postural screenings that were done in the schools in the United States in 1914 for a variety of different reasons. And it chronicles all of those various screenings up into including scoliosis and draws out all of the negative issues. And then primarily, that is heavily focused on the fact that you have a condition that is primarily females, adolescent females. Unfortunately, there are, through the process of that over the years, that has caused a lot of scarring in a lot of people. And they've written about that. So for us, the challenge is not to dwell on this negativism, but to take that in terms of our motivation going forward. We need a screening process that's not only effective and efficient, that not only clinically does it, but that can be applied in a very dignified manner. We don't have to touch the child, where we don't have to undress, where we can find out as quick as possible whether or not they should go on to x-rays and other more aggressive diagnostic and treatment processes as they go forward. That's the challenge that we have. We need to get evidence-based outcomes for the early detection of scoliosis. We haven't done it. It's sort of the lagging child. You know, the surgical innovation has been absolutely unbelievable around the globe. Over my experience of the last 50 years, both professionally and personally, has been phenomenal. In the last 15 years, we've had an incredible increase in the amount of focus and attention on non-operative treatment, which has been phenomenal, and that's a growing tribute that can happen. But we haven't paid attention to the early detection side. We have to pay more focus, more brain power, and more money into that end. We just seem to have an imbalance, just as we did with non-operative versus surgical. We have an imbalance between early detection and prevention and treatment and correction. We've got to change that. And we have to change it, I think, in a dramatic way. Not for rewriting. For the last 50 years, we've been talking about the same thing, about the scoliometer or some other device like that, about the Adams forward bending test. We got to get off of that. We need a new directive, a new initiative. COVID-19 is providing some new motivation to us. We have new norms that are being developed. Like it or not, they are. Telehealth is starting to grow very much in very much way. I don't think it's going to go away. It looks like it's going to be here, more substantial than it was in the past. And I think it's and it is starting to include scoliosis, and perhaps we can use it as a screening tool as well to go forward. And that will take care of some of the issues that we have regarding postural screening at a population-based level. We also have recently new emerging technology that the FDA approved in terms of non-fusion technologies with growth modulation, whether it's the apifix, which is a little bit later in the process, or the vertebral body tethering. Now, that is extremely important from my perspective, because what that does is that brings the surgeon under the umbrella of the requirement for early detection. They were there, but now it's more so. We can't have growth modulation unless we get it early enough to get that child and be able to do the effective things that we can do. So that brings all of us now together in the umbrella. Early detection is important for every single community now, so that together we can hopefully work to it. With everybody at the table looking at early detection, we are definitely confident and hopeful that we can come up to a better resolution. We need to change that paradigm. We need a safe, effective, efficient, evidence-based, and dignified detection screening method to prevent progressive idiopathic scoliosis from burdening our children and resulting in spinal deformity in our adults. Screen out scoliosis. Thank you.
Okay, just stop share screen. Yeah. Thank you so much, Mr. Joe, for a nice presentation, and thank you for everybody for a nice presentation, Professor Grivas, Professor Rene, and Mr. Joe. And now we can start with the questions from participants, and I will try to see, do we have questions? Or now is the recommendation to participants that they can text and send us the questions, and our panelists will answer on these questions. Now we can wait, but before we have first questions, I can please, Dr. Rene Castelein, just shortly, you just mentioned in one slide that I know that is not part of your topic today, but just to mention the connection between right thoracic and left thoracic curves, the connection with organs.
Yeah, thank you. This is a study we did also maybe about 10 years ago, but the thing is that if you look at the normal population, so the people without a scoliosis, we looked at a database that we had in the hospital. We didn't take a CT scan for our study. We never have taken one CT scan for any of the studies. We always used existing databases. But if you look at those databases where they took CT scans for polytrauma or for infectious disease or for pulmonary disease, and then you can do measurements on the spine and the rotation of each individual vertebra in people without scoliosis. And if you do that, you see that the people without the scoliosis have the same rotation that you see in scoliosis. So what we found is that in the upper thoracic spine, rotation in normal persons, no scoliosis, upper thoracic spine rotation to the left, mid-thoracic spine rotation to the right, lumbar spine rotation to the left. And that has to do with organ anatomy, because we also studied people with situs inversus, so dextrocardia and the internal organs in a mirror position, and they have the rotation in the exactly opposite direction.
Okay, thank you. Thank you so much. Thank you so much. And now I'm just looking for a first question, and we have now questions that what's the more effective exercise to treat the scoliosis curve in right 23 degrees, 20 years old female? Yeah, that is always good to wrote that you ask for who is that question, but yeah, maybe Mr. Joe Bryan, could you give us the answer of that question? From your also perspective.
What is the most effective exercise for a 20-year-old?
23 degrees, 20-year-old female.
Well, that's a very good question. You know, it depends on who you look at. There is a variety. I mean, some would say the side shift is a very effective treatment for that. Is it a 23-degree thoracic curve? Is that what we're talking about?
Pardon?
I said, is it a thoracic curve? Is that what we're talking about?
No, they didn't say, just say curve in right. Yeah, I expect thoracic right curve, 23 degree.
Well, as you know, we have a variety of different. In the United States, the most used treatment process right now is the Schroth treatment that's being used. So, I mean, obviously, we require a specialist in Schroth to be able to identify for that particular person. It has to be patient-centered for that. So, I would be remiss to remember that. And as I said, we also have the side shift. A lot of people recommend that. The yoga people recommend the side shift yoga posture that they use. Basically, it's the same as the side shift to do that in order to maintain, obviously, at a 23-degree curve at a skeletally mature person. You know, we don't expect that to continue to progress, but depending on the other symptomatic issues that that patient may have, so again, it has to be patient-centered to determine what's appropriate for that particular person.
Okay, thank you. Thank you so much. Next question. In transverse plane, what happened? What is happening in the patients who has kyphosis together? Maybe this question will be good for Dr. Grivas and Dr. Rene Castelein. You can. Yep.
Let's ask my colleague Rene to.
Yeah, Professor Rene, could you answer it?
Probably I can comment on this later on, but.
I was hoping Theo would answer, but the issue in kyphosis is very different. And actually, you can rotate your spine in lordosis and you can rotate your spine in kyphosis. And in most cases of scoliosis, practically all cases of scoliosis, the spine is rotated in lordosis. So rotation in kyphosis is a different animal, basically. And you can see that in Scheuermann's disease, but you can also have the impression that you're looking at a kyphotic spine because T2 is in a kyphotic position compared to T12, but everything in between is in a rotated lordosis. So I think we have to distinguish between most cases or practically all cases of true scoliosis where the rotation is always in a lordotic direction between each individual vertebra, and the cases where you have a kyphosis that can also rotate, but you should not call that a scoliosis.
I would agree with Rene, and I think that kyphoscoliosis and lordoscoliosis are not similar manifestations of the disease, because in the thoracic area, in the thoracic spine, it's connected to the thorax, which is very important in biomechanics of this area. And as all of us were aware, when we are doing screening, the first thing we see and what it is discriminating a child who will be referred from a child who will not be referred is the hump, the rib hump. That means that there is a deformity of the thorax in the transverse plane. And this deformity, especially in the very young children with straight spine, may be present at least at 30%. To me, it's very important, and this indicates that something is happening above the level of the spine, probably in the nervous system, and creating, you know, a symmetrical loading of the thoracic cage and also a symmetrical acting of the nervous, especially of the autonomic nervous system, and especially on the drainage of the one and the other side of the rib cage. And this has to do with the deformity of the thoracic cage and the creation of the hump, which is initially observed, and then we see the deformity of the central axis of the spine. But what is, you know, creating the lordosis and what it is creating the kyphosis, I think that it is very difficult to describe.
Yeah, thank you. Thank you so much. Next question is, how do you explain from biomechanical point of view the presence of kyphoscoliosis if the lordosis or backward shear force is essential laser for rotation instability to occur? Yeah, that's for Professor. I expect it's for Dr. Rene Castelein.
I would like to try to answer that. I think this is very much a matter of definition, and this is very confusing for most of us. But the thing is that if we talk about kyphoscoliosis, it means that if you look at the position of T2 and T12, they are in a position of kyphosis. And when you look at the patient from the side, you see a sharp kyphosis sometimes, or more than sometimes. But when you look at, so if you look at the global orientation of the spine may be in kyphosis. But now if we go to the level of each individual vertebra and we analyze the position of the vertebrae, they are in extension. Although the whole spine is in kyphosis, the area between T2 and T12 is in a rotated lordosis, which was also described by Somerville and by Rowe and by Dixon later. And this has been known for a long time, but it's very confusing to talk about it, because when I say every scoliosis is basically a lordotic deformity, I'm talking about each individual vertebra compared to its neighbor. These two vertebrae are in a lordosis, but the lordosis is rotated to the side. But if we look at the whole configuration of the spine, it can be in kyphosis. So when we talk about kyphoscoliosis, it would usually mean that the same story that I just told still holds true, because all the vertebrae in between are in a rotated lordosis. So I hope that makes it a little bit more clear, but this is usually very confusing. You hear that at many meetings, the discussion about kyphoscoliosis or lordoscoliosis.
Yeah. Thank you so much. Next question is for Mr. Joe Bryan. Is there difference in degrees according to Cobb when doing the X-ray formetric device? Yeah, you present the formetric, and I think that is a good question for.
Yeah. Well, in our experience, yeah, I mean, the formetrics has been utilized quite well in terms of, and I mean, it's fairly correlated, but it depends. We've found in the extremes, whether in large curves or in smaller curves, sometimes there is a distortion between it, and we seem, even when we're using landmarks, it still seems to be distorted. It's not an exact correlation within there. But for the majority of patients that we see, we do have a fairly good correlation between the X-ray Cobb angle and the formetrics. But again, we're not using the formetrics, though, as a diagnostic tool for us. It's no different, really, than a scoliometer in the sense we're just looking at it to track with that individual patient and to be able to identify and begin to quantify what that curve is. So for that purpose, for us, in our hands, that works very well.
I would like to comment on this. In our scoliosis clinic, we are using formetric as well. Initially, when a child is referred to be initially examined, of course, if there is a pronounced hump and the age is about, let's say, 12 or 13, we are prescribing an X-ray. And also, we document the back of the child using the formetric. During the follow-up, initially, we are doing formetric. If the one and the other formetric are similar, or, there is not a lot of change, then we do not ask for X-rays. And this is very helpful, and for us, this is the benefit of using surface topography.
Yeah, if I can give a comment, it's also very interesting that I know that Dr. Rene has a Scolio scan, and Dr. Grivas also is using the formetric. We can say that these devices are good to following the patient and maybe to avoid some X-rays if we see that everything is stable, And if we see that some curve is progressed, definitely the best device for cob degree, for cob angle, and for position of the spine is the X-ray at the end. That is what I think and what I can say. Okay. Next question is for Professor Rene Castelein. What do you recommend as a surgeon if you just see posterior forks on X-ray and not scoliosis? Do you recommend patients to start exercise program, or what is recommendation?
So the question is, if I see someone with a large posterior inclination, posterior shear, but no scoliosis, is that the question?
Yeah, it's not scoliosis.
Well, you know, that's a very difficult question, because I think the sagittal plane can be very abnormal, and we still see in the coronal plane that the spine is nice and straight, but we're not used to doing preventive surgery on the sagittal shape. I would definitely, if I see a sagittal shape that I don't like, that I think may be at risk for starting to give problems, rotation or pain or other things, I would definitely start an exercise program. Try to modify that sagittal shape. And then I have cases, of course, I have also cases where, for instance, the kyphosis is very severe. And usually if you have a severe kyphosis, underneath the severe kyphosis, you have a very steep area of the spine and a sharp lordosis. So I think it's very justified to operate people for extreme kyphosis also. People debate that because the risks may be a little bit greater, proximal junctional and distal junctional problems, maybe some more neurologic damage. But I think by treating that problem, you may prevent in the future problems like pain, maybe not in the kyphosis, but in the neck above or in the lumbar spine below, where people compensate. So I think it's a very difficult question and difficult to answer black or white, but I think it's something that should be followed. I would definitely take that very seriously and try to modify with exercises, maybe give a brace, and try to get that sagittal shape in a more favorable alignment.
Thank you so much. And next question is really interesting because we can discuss, and maybe that is the really interesting topic. When is the time for surgery, and what is the border? Then we can use the conservative treatment. I mean, exercise and rigid brace. And question is it possible for conservative treatment, exercise, rigid brace, to decrease 65-degree scoliosis to become less than 20 degrees, biomechanically speaking? Yeah, we can discuss, all of us can discuss about this question. Maybe some of you can give the answer, and after that, it may be interesting topic to discuss. What is the border?
Let me comment on this. A patient having 60 degrees of curve, to my opinion, this scoliotic curve will be very, very not pliable. You know, you can't correct it. Even though if you are doing bending X-rays, you can't see a lot of correction. It is very stiff. There is no, I don't believe that there's, unless it is, you know, neuromuscular, and in a very young child with the this sort of scoliosis in a very young child of neuromuscular etiology. Probably you can, you know, straighten more than in an adolescent with 60 degrees. So the answer is, my opinion is that the brace cannot correct the curves of such severity less than, you know, 40, maybe 30 degrees, 50% correction. And this would be, you know, miracle. This is what I believe.
Yeah, I'm also using the conservative treatment, short method, and it's even, let's say it's almost not possible to talk that we can decrease the scoliosis from 65 degrees to 20. And also it's very important what is the age of this patient. It's a totally different perspective if we have patients pre-puberty, puberty period, let's say adolescent or adult. But now we can, maybe you can give idea to our participants. For example, what is the border when we can recommend the surgery and when we can recommend the conservative treatment? What is your recommendation? When is the last option and when we can give to parents to choose and to get this decision?
Nicholas, according to the classic recommendations written in the books, depends upon the level of the spine. If it's a thoracic curve, and we have to consider also the age of the patient, the menarcheal stage, and we have to know how much growth it is expected in this child. And if we can, wait in order to have some growth of the spine and not disturb the process of growth of the spine, it's what it is usually done internationally. It is something like 50 degrees of thoracic curve when we decided to operate upon. But in lumbar spine, it's a little bit less, 45 degrees would be the indication for operative treatment, because this part of the spine is more, very flexible, and it's expected to have more, a remodeling towards the deformity. So this is what it is classically done internationally. I don't know if Rene has to comment in a different way.
No, I fully agree with you, Theo. You did a lot of studies on this topic, and I agree with you. The only thing is, maybe we should not only focus on cob angle. I think if an adult with a curve of about 60 degrees would come to me, I would look at a number of other things also. First of all, I would want to have a very extensive history. Is there pain, or is it something someone else noticed? And then I would look at balance of the spine and shoulder level and those kind of things, and function. So if these would be pretty good, then I would not necessarily think that that curve of 60 degrees needed to be operated. It will probably progress, I know that, but some people have good postural control and they can last for a long time, and I'm not sure if a fused spine then is better. So the progression would not be very, very quick or very dramatic. I might wait if there's, good balance, not a lot of complaints.
Nicola, are you speaking about adult scoliosis or about idiopathic adolescent?
No, generally, now I speak about idiopathic adolescent.
Different if you are speaking about adults with 60 degrees and if you are speaking about an adolescent with 60 degrees. There is no doubt it is quite different issue.
Yeah, I talk about adolescent idiopathic scoliosis.
Because I thought he was focused on probably older people. Was it so, Rene?
Well, I'm talking about an adult, fully grown, 35, 60 degrees, that has been there for a long time. I would watch for progression, but I might not decide to operate.
If I can answer it a little bit differently in terms of, it depends. Because it's not just the spine, it's not just an x-ray that tells you what the cob angle is, it's just not the expertise that tells you what the prognostic potential is for that. It depends on the patient, the parent, the child, and certainly in the adult deformity, it is very much upon the patient themselves. They may choose to live with what they have. It's how's their life, what's their quality of life, what is it that they want to do out of that. I don't think, how aggressive do they want to be, how disciplined are they? How much are they going to comply with conservative treatment? The same with the child, Some children just will not comply. So that changes the prognostic factor of what our knowledge base says. So it really, at the end of the day, is that patient, whether it be the parent who's the patient a lot at that time, in the child, in the adolescent, or in the adult form. And, you know, they've got to be as informed as much as possible, and then make their choice in terms of what they, you know, in essence, you know, you make your bed, you got to sleep in it. So you've got to realize what's going to happen, and choose the path that is best for you at that particular point.
Okay, thank you so much. And for the end, we have more questions, but I would like to close just to make some comments and to ask Mr. Joe Bryan. Mr. Joe Bryan, could we say that the best prevention for scoliosis is the early detection? And also, could you give us the comments, could the bad posture cause scoliosis?
Well, let me answer the first question first. Scoliosis by itself is not the issue. Progressive scoliosis is really the problem that we're trying to address. And yes, in our perspective, detection is the best first step for prevention of that progressive scoliosis that allows us the more opportunity to provide optimal care. That optimal care depends on what the situation is, at what time, what the patient wants, what can be provided to them, both conservative and surgical, particularly in light of the new emerging technologies with non-fusion technologies, et cetera. So there's going to be a growing group. But yes, at the end of the day, for us, early detection is the first and best step for prevention of that. To your second question, would you repeat that again?
Could the bad posture can cause the scoliosis?
Can back posture cause?
Bad posture.
Oh, bad posture.
Yeah.
Well, clearly you can have, you know, you can appear to be kyphotic, you can appear to be scoliosis in a functional scoliosis, but no, technically speaking, you have to have a greater than a 10-degree scoliotic curve, and there's a difference between a structural curve and a non-structural curve that's there. You know, I suppose if you lived for 1 million years with that asymmetrical force, Rene is probably best to answer that question in terms of how many newtons force do you need. I think you need 10 newtons of force in order to start to reform the bones. So if you applied more than 10 newtons of force over a certain period of time, you would probably cause a scoliosis.
Well, I'd like to comment on that. I think, first of all, I don't think scoliosis is very much in the bone, especially not in the beginning. We've shown that, and Professor Grivas has shown that it's in the disc. And the disc is easier to deform than the bone, of course. But I think the problem is that what we call bad posture and good posture, I think these children that are likely to perhaps develop a scoliosis, you would usually say they have excellent posture because they're way up, they're straight, and they hardly have any kyphosis. And those are the ones at risk to start developing a scoliosis later. So maybe it's not good posture or bad posture, but it's very individual. But the ones that we say have good posture may still develop a spinal deformity.
Yeah. Thank you so much. Thank you so much for your time and for contribution to make this event bigger. And it's a big pleasure to talk with all of you and to meet you online. I hope that sooner, next year, we will meet each other personally and to continue to talk about scoliosis. Thank you so much. It's very important for all of us to hear from you what is the scoliosis. And also, I just have to say that we had yesterday 347 participants, but today we had between 140 and 150 participants who follow us, maybe because the problem is of the different time zone, but all of participants who missed this session can follow our YouTube channel and can also follow our Instagram, Facebook, and website, and all information will be there.
Thank you very much, Nikola. I enjoyed it very much.
Right.
Thank you, Nikola.
Thank you so much.
My esteemed colleagues too. Thank you very much.
Have a nice weekend.
Thank you.
Good weekend.
Good weekend. Bye.
Bye-bye.